So thank you very much for inviting me. I actually recently left the University of Kentucky. I graduated, so I'm here representing the contingent of Brayfix and Justin Frazier. I recently moved to the University of Texas Health Science Center, and if anybody visited Houston in June, happy to be back north. I left with 100 degrees, so it's good to be back where it's cool. I actually have no disclosures, and then I just want to go over the people that helped put this together. So all the clinical work was done by Justin Frazier. Our neurosurgeon with the group, Gregory Binks, was in charge of all of our preclinical. Jill Roberts and Amanda Trout helped with all the in vivo and in vitro work. So just how we're going to go throughout the outline. We're going to go from bench to bedside approach. So we'll look at our in vivo stroke model, our intra-arterial model, and then we're going to look at two sets of drugs, verapamil, which is an L-type calcium channel blocker, and then verapamil and magnesium being an NMDA modulator or some glutamate. We're going to equate those verapamil in vitro and vivo to our phase 1 clinical trial looking at verapamil and super selective administration, verapamil during recanalization following acute stroke, and then doing a combination therapy of verapamil and magnesium, looking at the in vitro and vivo, and then explaining that the most recent Maverick or magnesium and verapamil after recanalization. So I'm sure most of you are familiar with the stroke models that we perform. So we actually do tandem transit common carotid middle cerebral artery. So we isolate common carotid. We isolate the middle cerebral artery by drilling a burr hole over it. We clamp the common carotid. We clamp the common carotid, and then we place a filament underneath the middle cerebral artery. So before we do all this, we have a very nice blood flow through the MCA using laser Doppler. Following occlusion, we have about a 90% drop, and then 5 minutes following the removal of the clamp and the filament, we get about a 50% reperfusion. And this also gives us a nice ischemia, as you can see right here in the cortex. So we have a very cortical stroke, and we perform ours for 60 minutes. So that's our in vivo stroke model. And then our intra-arterial pharmacotherapy delivery, we pretty much just piggyback on our stroke. So we've already isolated the vasculature in the neck. And what we do is we take where the clamp is down here, and we just move superiorly to the, I guess I should move over here, move superiorly along the common carotids to the bifurcation of the ECA and ICA. We temporarily occlude the ICA. We permanently occlude the ECA. We then insert our microangio tubing within the ECA down to the bifurcation of the ECA and ICA. And then about 5 minutes before the stroke is done, at 60 minutes, we'll perform all this. Once that's done, we'll remove the filament in the underneath the MCA. We'll remove the clamp on the CCA. We will then allow the CCA to perfuse through the vessels for 5 minutes, therefore giving our reperfusion. And so we have a guaranteed recanalization with our removing of the clamp and the MCA filament. And then we can administer our drug using our tubing, taking the drug from the ECA, and it flows from the CCA up into the ICA, which is what endovascular thrombectomy does. So before we just started injecting, we had to figure out what dose we were going to give. And so we did a series of India ink injections using our model, injecting the India ink starting at 10 microliters per minute at a volume of 100 microliters. And if anybody's ever done this study, you probably realized that 10 microliters at 100 microliters, the entire animal turned black. So as you can see over here, we realized very quickly that we were a little too high. And so we started titrating our dose down. And what we found was that 2 microliters per minute at a volume of 10 microliters gave us good ipsilateral MCA staining, a little bit of contralateral because of the azygous ACA. We saw only ipsilateral hemispheric staining, no contralateral, and then we didn't see any systemic staining looking at the liver, as you can see in the 100 microliters at 10 microliters, and then our 2.5 microliters at 10 microliter injection rate and volume. So now that we had our stroke model and our intra-arterial model, we wanted to look at a drug that's readily available. We only chose drugs that are FDA approved. The dead battery, FDA approved, and I teach negative drug anatomy. All right, one more. Let's try this again. We only chose drugs that were FDA approved, and so verapamil and magnesium fit this bill. So we wanted to see if verapamil worked directly on neurons or if it was just through the vasodilatory effects. So we took primary cortical neurons and exposed them to oxygen glucose deprivation or stroke in a dish. And so we, of course, had our control, positive, and our negative control. And then following a 30-minute oxygen glucose deprivation, we reperfused with 3 doses of verapamil, 250 nanograms, 325, and 500. And then we looked at a hook staff space, simple cell survival, and then neurite branch using MAP2. Once we did this, we then went into the animal using our stroke model, our intraarterial. We injected either saline or verapamil intraarterially. We looked at blood flow measurements to confirm vasodilation, physiological measurements to make sure that it wasn't deleterious, behavior, and post-analysis. And so what we found was in our OGD, the verapamil actually did show a direct neuroprotective effect of our neurons following our 30-minute OGD. And it was actually in a stair-step fashion where we went from our 250 nanograms to our 325 to our 500. So we chose 500 nanograms as our optimal dose. And we, of course, use this based on calculations from the dose used in the clinic to treat cerebral artery vasospasms. So now that we know it protected neurons, did it also help with function? And we wanted to look at primary, secondary, and tertiary neurite branching. And when using MAP2, we then went through, found our neurons, and then measured the branchings on a primary branch, a secondary branch, and the tertiary branch. And again, found that our 500 nanogram dose was the optimal dose or had the greatest length per branch compared to our positive controls. So we showed that verapamil can actually protect neurons following a 30-minute OGD. So what happens when we inject it into the animal following our 60-minute occlusion? Well, we wanted to see if there was actually a vasodilation compared to saline. So what we found was using laser Doppler, where we placed the filament directly over the MTA, as we see our baseline measurement, we see our occlusion, we see our reperfusion, and the arrow indicates drug administration, and then we followed it for 10 minutes. And our infusion rate is 2.5 microliters over 10 microliters, which is a 4-minute injection. As you can see that we see no difference between the treated group and the control group, or saline versus verapamil. We also looked at laser speckle, where we choose two regions of interest, the contralateral MTA territory and the ipsilateral MTA territory. And we plotted those as a baseline measurement. And of course, when you occlude, all the blood is found in the contralateral MTA, and then we reperfuse with our drug, and we see that there's no change or no difference between the two groups as the blood flow starts to return back to the global perfusion. So did this have any physiological effect? So we then looked at mouse ox, and we wanted to see if there was a difference in heart rate or blood pressure. And as you can see in our baseline measurements with the animal here, following reperfusion and drug administration, we see our heart rate for our verapamil group stay high, close to baseline, but our control group dropped significantly. We also saw in our blood pressure that our groups both started low, but our verapamil group maintained or increased slowly, whereas our control group increased significantly over the next 10 minutes. So we found that verapamil helps maintain heart rate and blood pressure during injection and following reperfusion with verapamil. So how did this do functionally? So we wanted to see how the mice performed on both a forced motor movement and a free roam motor movement. And what we did was we did rotarod, or a mouse on a treadmill, and then open field, a mouse in a box. And we trained them on the rotarod for 3 days so they can learn the task. Then we induced our stroke, and what we found was that it expected the control group that received saline dropped off and could not perform as well. But our verapamil treated group continued to learn. And they actually, over post-stroke day 1 to post-stroke day 5, did significantly better than our control group. But on post-stroke day 7, we did not see a difference. We included a naive group here to show that the learning continues. On open field, we did the same thing, except we just did them on post-stroke day 1 and post-stroke day 7. So again, we had our baseline measurements, and then following stroke, of course, both groups dropped. They did not feel well, so they weren't moving. But going from post-stroke day 1 to post-stroke day 7, we found that verapamil treated group started to increase, where our control group started or continued to decline over time. So how did this look on infarct volume? So we've shown that it's safe physiologically. There's no real change in blood pressure. And then we have a functional outcome. We saw a significant reduction in infarct volume in our saline treated group versus our control treated group. And we can see here that we're in the cortex, and then our treated group actually has a significant reduction in infarct volume. So how does this look histologically? Well, we wanted to look at 3 measures. We looked at tunnel, which measures apoptosis, GFAP for astrocytes, and new end for mature neurons. And what we found was, again, that in our infarcted region only, where we expect to see dead cells, our control group had a higher incidence of tunnel positive cells compared to our treated group. We, of course, again, expected to have more astrogliosis or astrocytes within the infarcted region in the control group versus the treated group. And we hope to see, and we did, more neurons within our treated group infarcted region versus our control group. So this led us to a positive effect in moving into our first phase 1 clinical trial. And it was just a phase 1 safety trial led by Justin Frazier, where we only had a treated group. And for all those patients that were eligible for the thrombectomy, 104, about 10% or 11 were successfully enrolled. We had to get family consent. And of those 11, none met our primary endpoint of intracranial hemorrhage. We did receive permission from the University of Kentucky IRB to follow those that, while they were not enrolled, did receive verapamil for vasospasm and those that did not. So the groups are not, or 31 and 62, and we had both 3 in each group receive or meet the primary endpoint of intracranial hemorrhage, but it's not difference between the two. If you were wondering what the demographics were, we had male and female. This is in Kentucky, so we are in the stroke belt, so our ages were high, but we did have a few young people that were in with it. We present our stroke scale, our aspect, and our CTA scores. And then if you were interested, we also had our last known normal recanalization. Only one person did not receive TPA, and of course our thrombectomy devices. And then we did our TICI scores 2A and above, and then our MRS 30 to 90 days. While we didn't see the great scores that we were hoping for, we did find that it was safe to infuse in a short-term manner. So now that we know that verapamil is safe in both a preclinical clinical setting, we also know that verapamil is just an acute drug. It treats just the L-type calcium channels. It's a first pass. We needed something that was more delayed or more chronic, and that's why we came up with magnesium. Magnesium has both a preclinical and a clinical history within the literature. A lot of people are familiar with it. It's FDA, the drug that's readily available. There are some other drugs that we looked for that showed efficacy as well, but it was harder to get. So our model was set up the same in our in vitro and our vivo. We took primary cortical neurons, exposed them to oxygen glucose deprivation. We again have our 500 nanograms of verapamil we found from our first study. And then again, we looked at the literature and found that 2 millimoles of magnesium was our best. And then we combined the verapamil and magnesium for a combination. We're in the process of analyzing all this data. So right now we only have percent cell survival. We hope to have the MAP2 or neurite branch done within the next couple of weeks. We did our in vivo model. We found our intra-arterial delivery. Again, we have our control for saline. We did a magnesium group independently, a verapamil group, and a combination group together. And we looked again at blood flow, physiological measurements, behavior, and then our post-analysis would be our histology. So as you can see, once again, our treated groups of magnesium and verapamil are much better than our control negative, but our combination group is far better than the two, and it showed no difference between the plus or the primary cortical neurons that did not receive a stroke. So we're having a positive effect here. So we're hoping to see the same effect in our neurite branching over the next couple of weeks when we analyze. So did we see any difference in laser Doppler or the blood flow movement through the middle cerebral artery? And again, we have our baseline measurements. We have our about 90% occlusion, or drop in blood flow once we do the stroke. And then following reperfusion and drug administration, we again see that there is no difference between the groups with blood flow through the middle cerebral artery 10 minutes post. Physiologically, we also found that it is safe. So again, we see that there is no difference between the groups in heart rate or blood pressure. But the effect that we saw on the previous verapamil group, where we saw a positive functional effect, did not carry over. So here we did open field and an in-house developed neuroscore. And while we looked at just post-stroke day 1 to post-stroke day 7, because previously we saw that the control group declined where the treated group, verapamil itself, did better, we did not see the same positive or significant effect, but we did see that the combination group did do better overall than all the other groups on the post-stroke day 1 to post-stroke day 7 delta value. For our neuroscore, which we loosely modeled off the United Stroke Scale, again, we saw that our combination group and our 2 treated groups did better than our control group, but not significantly different amongst the ones. We then looked at infarct volume. We were able this time to do imaging at post-stroke day 3 using a T2, our scan, and a DWI, and we again saw no difference in the groups at post-stroke day 3. But at post-stroke day 7, we did see all 3 of our treated groups lower than our control group, albeit not significantly different, but we are repeating the study and we hope that will get us to significance. The closest one would again be the verapamil group that received it, and it was like 0.055, I believe. This led us then to look at our histological measures, and once again we looked at apoptosis, astrogliosis, and mature neurons. And again, we see that all 3 treatment groups, including the combination group, are reduced compared to our control group in both tunnel or apoptosis within the infarcted region and GFAP within the infarcted region, but we do not see any real difference. And again, even our control and our combination are about the same in mature neurons within the infarcted region. So not the positive results we were hoping for, but still it shows that combination therapy is feasible. We have just started our phase 1 clinical trial looking at combination therapy. It started in 2017 at the University of Kentucky under the guidance of Dr. Justin Frazier and Steve Grupke. They were able to consent 12 patients and treated 7, 5 in the study drug group and 2 in the placebo. And again, they did not meet the primary endpoint of intracranial hemorrhage. And they also saw no systemic side effects related to the combinational therapy of verapamil and magnesium. And so far, they say that the initial outcome is looking positive. So with that, if you have any questions, while I am now in Texas, I'll be more than happy to forward your emails on. But Justin Frazier is in charge of both SAVOR1 and Maverick, and Greg Dix, who is at the University of Kentucky, but is, I believe, leaving for Tulane soon, is in charge of our preclinical studies.